Okay.
Welcome to AETCM, the emergency medicine channel. So shall we start?
Sure.
There's a case in the ER where young adult who has slipped and fell in her bathroom and she had a injury, facial injury, sir. Coming to the primary survey, as soon as the patient came, we started.
What is the age?
Age 20-year-old female, sir. Primary survey, airway is patent and the patient is talking and there is no any pulling of secretion and there is no hoarseness of voice. So the airway is patent and there is cervical mobility present without no pain on movement. Cervical spine tenderness, check for it. There is absent cervical spine tenderness, sir. Next, coming to the breathing part, patient is having bilateral air entry equal, saturation was 99% and respiratory rate was 18 per minute. Next, coming with the circulation part, patient's BP was 120 by 80 and pulse was 86 per minute. All peripheral pulses were palpable and capillary refill time was less than 2 seconds, sir. No active bleeding site seen. And next, coming with the disability, GCS was E4, V5, M6 and pupils were bilaterally reactive. And then coming with the exposure, there is no any limb injuries. The patient was normal, no hyperthermia was noticed, and blood sugar was taken. GRBS was 120 mg per dl, sir. And so the primary survey, we can conclude that there was no any effect to in the primary survey. Now coming to the secondary survey, the patient has no any history of allergies, not on any medication, and there is no any past history of such trauma, and the last meal was half an hour ago. The events leading to this injury was patient, a 20-year-old female.
So she had meal with this injury?
Before the injury.
Just before the injury.
After having the meal, she went to the washroom, and when she was in the washroom, she has slipped and she fell onto the sink, so the face hitting the sink, post which she had seen there was a chip of her front lower incisor broken, for which she has come to the emergency department, sir.
It's the lower incisor.
Lower central incisor injury was there, sir, for which she had come to the emergency. That is the case. So for which initially on examination part, the facial symmetry was there. There is no any obvious abrasion or laceration over the face. There is no bleeding in the gingival bleeding is present, and mobility inspection wise there is no any like dislocation of the tooth or anything, and mobility wise it's not movable. The teeth is fixed in the position itself, and on touch she doesn't say feel the pain of it.
Doesn't feel the pain may mean numbness, or
she doesn't complain of pain like extra, like on palpitation there's no extra pain, she says.
Okay, so the general health aspects have been taken care of.
Yes.
When the patient fell down, the first thing, if there is no apparent excessive bleeding or anything, first thing we need to ask what caused the fall. Is it a syncope, or is it some other more serious CNS issues which caused the fall? As far as the dental injury is concerned, that itself is not an emergency and we can deal with it. Okay. So when you are looking at the kind of injury here, generally when people fall down with their face down, it is the upper central incisor which is usually injured. When it is the lower central incisor, because upper central incisor is the more prominent tooth, it is actually covering the lower central incisor. When there is lower central incisor injury, it is likely that she landed on the chin, and then the whole lower arch hit the upper arch and then caused this fracture. That is the possibility. Lower teeth itself directly hitting is possible, but that is less likely. So if there has been a hit on the chin, we should actively look for a condylar fracture, indirect fracture of the mandible. There may not be a swelling at present, but if you ask specifically, you ask the patient to open and mouth while palpating the condylar region, preauricular region, there may be pain. there may not be an actual fracture of the usually more common kind of fracture is subcondylar fracture of the mandible. When you hit on the chin, always you look for subcondylar fracture of the mandible, usually bilateral, 3 fractures, bilateral subcondylar fracture and the chin fracture, or without the chin fracture, bilateral subcondylar fracture. But in such cases, usually there will be a problem with the dental occlusion. The dental occlusion is fine and there is no pain on mouth opening. Generally, you can feel that the condylar region is intact. But still, without fracture, there can be contusion of the joint space, which can cause fibrosis later and cause problems later. So that is one thing that you should look at in this kind of situation. Okay, let us go away from the fracture and go into the tooth itself. When there is an injury to the tooth, this tooth has hit the upper tooth. Yeah. Apparently, not 100% sure, but apparently this tooth has hit the upper tooth. So we should look at the upper tooth also, whether there is mobility, etc. As regards the injury to the dentoalveolar structures are concerned, first thing that you are looking at whether there is a dentoalveolar fracture. So you should actively palpate and try to maneuver the teeth. Dentoalveolar fracture would mean that a mass of 2 or more teeth are moving as a unit. Does it mean that they need treatment immediately? No, nothing like that. Undisplaced dentoalveolar fractures can be left alone also, even left alone. Okay, dentoalveolar fracture is one thing. Second thing is a tooth dislocation. I will just talk about tooth avulsion in a while because we need to talk about that a bit. First, let us look at the fracture. As you said, one part of the tooth is chipped off. When we learn about tooth injuries, there are several grades of tooth injury. It is called class 1 to 3. Ellis class 1, 2, 3 fractures. Ellis class 1 means only enamel is fractured. Class 2 means enamel and dent in that segment is fractured. Class 3 means the pulp is exposed. Okay, that kind of. So if it is only a hard tissue fracture, not exposing the pulp, all that we need to do is to just smoothen the surface so that there is no injury to the tongue and adjacent structures. It can be dealt with later. Then it is very important to have a radiograph because externally we see an injury. There may be a root fracture inside. There may be root fracture. There may be a dentoalveolar fracture. There may be some kind of subluxation, etc. So it is important to look for dental occlusion. Is there an excessive impact on the upper tooth with the lower tooth now because it is extruded? Okay, look at the upper tooth also whether it is tender on percussion, whether it is mobile. So if there is a root fracture, the prognosis for that tooth is poor. We may have to remove that tooth. Okay. In some cases, when only the root tip is fractured, that may be probably redeemable situation. But if it is fracture of the root at a higher level, or there is a fracture of the neck separating the root and the crown, it is usually that goes for extraction. When it is at least 1, 2, or 3 fracture, wherein only the part of the crown is fractured, it is you don't need to extract definitely. Okay, you need to just do something to either build up the tooth if it's only an enamel fracture, or if the pulp is exposed, you may need to do a root canal therapy or endodontic treatment. That said, it's almost 100%, more than 90% chance that this tooth will need a root canal treatment later, because this impact has happened and the blood supply to the root comes in through a very, very minute hole in the apex of the root. It is likely that there is some edema in that region, and now you find that the tooth has pain and the neural things are all intact. But in course of time, what happens is that in course of time, maybe in the matter of a year or so, that tooth gets becomes non-vital, and then it gets infected because we are not following up. In course of time, after 5 years or so, these patients come back with an infection. That very commonly happens. The tooth gets discolored, infection in the gums, etc., periapical region of the tooth, etc. So we should know that these teeth will probably need root canal treatment later. One common practice is to call the patient after 3 weeks, 3 weeks or 3 months, after a particular period of time, and check the vitality. There are ways to check the vitality using electrical stimulation, using eyes, etc. You can check the vitality of the tooth. So immediately, if you check the vitality of the tooth, you maybe because of the edema and all, you may not find vitality. Tooth may be vital. So check the vitality again after a particular period of time, and see whether that needs an endodontic treatment. Is the way you treat crown fractures, partial crown fractures. If it is only an enamel or dentine fracture, you can build it up. Build it up later with there are materials for that. Tooth filling materials are there. If a significant portion of the tooth crown is lost, you can place a crown, artificial crown. That may be required. Our filling material won't stay if significant part of tooth is already lost. That is about the fracture. Okay. Of course, you should look at the other teeth also, adjacent teeth and all. Now about tooth avulsion. Tooth is out. What we should know is that now the blood supply is severed also. What we should know is that there are living cells which attach, living cells in the ligament which attach the tooth to the bone. So there may be living cells there. So if the tooth is lost, tooth has come out, it needs to be cleaned and it needs to be preserved wet. So that it is likely that we can replace it in the same socket, and of course it needs an endodontic treatment, and it can be it can be redeemed. The situation you don't need to remove that tooth. So one question is, suppose the tooth is lost, patient falls down and the one tooth has come out, what to do is one advice which we need to give the patients. First of all, you need to clean it off contamination. Do not brush, just do not touch. Do not touch the root. Touch only the crown, and clean it well in running water, and then keep it in some viable place. Best thing is the socket itself. Keep it in the socket. Maybe you can't do that for children, small children, because they may swallow. And put it in the socket, tooth socket itself, or they say in the mouth itself. If the patient is fairly conscious enough, oriented enough that they won't swallow, in the mouth itself, that is a second best option. Or in saliva, patient saliva, collect the patient's saliva and keep it in. Or ringer lactate. There is a solution for that. There is a solution called Hank's balanced salt solution, which the Hank has designed a solution, isotonic solution with a lot of magnesium phosphate and sodium carbonate and all that. That solution is there, which is the best medium for transport of an avulsed tooth. But of course, that is not usually available everywhere. In a setup like a hospital, if the tooth has fallen, ringer lactate would be a good option. Milk is supposed to be milk, coconut water. When you tell the patients, what are available at home, milk, coconut water, etc. are the commonly advised media for transfer. And then after you get the tooth, you can inspect the socket. The problem is that there may be fracture of the socket and it may not correctly fit in there. That you have to look at, and you suture off the soft tissue, everything, and place the tooth back in the socket, and you need to splint it. There are different ways of splinting. You can splint using stainless steel wires, and there are arch bars available. You can also splint it using the dental cementing materials, which helps to stick on to the tooth. You can use metal wire plus this cementing composite materials. There are fibers available for splinting alone. You can use that fibers and composite material for splinting the teeth together. That is the next step. Instruct the patient not to bite on that. Plus, very importantly, relieve the dental occlusion. Trim off the opposing tooth so that it is not biting on this tooth fully. These are the things that we do, and then of course, if it is ours, then we are putting it back. We do endodontic treatment immediately. One problem with these teeth is what is known as ideally, if it all heals well and all, it's very good. Periodontal, along the ligaments, the cells are preserved and it attaches to the bone. That's what we want. But in many cases, what we see is that there is a problem known as external resorption. Over a period of time, you find that the external aspects of the root, when you take the radiograph, starts resorbing. It is very late before patient starts to have any kind of pain or anything. In many situations, you take a radiograph or something else. After many years, you find that only the root canal filling is there. The root has resolved off. So root external resorption is a problem, because of which, in spite of all this work, you may need to remove that and have some kind of tooth replacement later. That's it.
Thanks.